The following presentation is about arthroscopic repair of multidirectional instability. In this case, a young athletic college individual has symptomatic instability. Contrasting arthrogram and non-arthrogram MRI, we can see a big difference in detecting the patulous capsule. While the capsule is patulous in both sets of images, the arthrogram may prove advantageous. Some centers don't like arthrogram as much. I find it very useful in this condition. On the axillary, once again, you can see the capsule is very large. Sometimes you see the capsule more large posteriorly. Examination under anesthesia is a critical component. This individual slides out the back, and as you saw before, slides out the front. The sulcus sign with axial traction that should reduce with external rotation also helps you. So in this case, I have both anterior and posterior instability with a positive sulcus. I like to make portals along the axis of the posterolateral acromion. I'll use percutaneous entry points for entering anchors, and I'll visualize from a standard lateral portal. Anteriorly, I'll make one or two anterior superior and anterior inferior portals. I like a lateral decubitus position. Diagnostic arthroscopy reveals an easy ability to drive around patulous capsule, a drive-through sign that's relatively easy. No evidence of Hegel tear, which is important. You don't want to be fooled by that. Here we're going to rasp the capsule. You can use a shaver as well with no suction. I want to create punctate bleeding. Next, I'm going to come in percutaneously. I want to get the angle for inserting anchors. I'm going to use all knotless suture anchors here. I'll get my way in, and as low down as I possibly can, I'll start to use. And I'll use a 30-degree curve here so I can angle towards the glenoid and not blow out into the bone. I'll drill this in, I'll place it, I'll set it, and I'll take my first bite using a suture lasso about 1 centimeter right here. Once I shuttle this through, I'll then complete the circuit, but I will not tie it down all the way. And that's the key. That's really the crux of this technique. By leaving these free and untightened, I can continue to move along. This is the next anchor placed percutaneously once again so I don't skive along the articular cartilage. Tied down just part of the way. Now I moved anterior, so I've got two up the back. I'm going to move anteriorly and get two up the front here. Once again, using a curved lasso device, I'll pass through. I'll send the shuttle through, and I did not tie it down all the way. Now I'm going to move more anteriorly. I'll bring the sutures out the front. They're not completely tied down, but this way I have two working cannulas in the front that are unencumbered. Try and get myself just a full cannula or full 3 millimeters away. I'll drill again, bite again. You can still see I'm way below the MGHL here. Progressive bite, cinch it down, make sure I'm not twisting around. Now I'll bring them all out the front. I want to put one more anchor in the back, and I'm going to capture the posterior portal somewhat. So right there, I've got the posterior portal captured as well. So I've got 3 anchors up the front, 3 up the back. I'm going to start tightening now. This is it. This is the zip tie. Nothing's been tightened before, so now they tighten. There goes. The posterior portal gets pulled in very nicely. Pulling it down, and now I'll tie down the front. Cinch, pull it down, right there. Pull it down just a little more. Pull down the most proximal one, and I may run through these one more time. And you really do get progressive tightening. It's a nice advantage. So cutting now, starting in the back, coming up the front. I can use this to tighten a little bit more. Release the next stitch. Release the next stitch. I've got 3 sutures up the front, 3 up the back. And the real advantage here is that I've been able to place each anchor without struggling with a previously tightened capsule. I'm not injuring the intact or normal articular cartilage, and I can really dial in my tension maximally at the end, sort of figuring out what I want the most. These are treated in a typical fashion for posterior or anterior instability, where the patient will be in a sling somewhere between 4 and 6 weeks. Start physical therapy about 3 weeks after their injury. Thank you.